Bismillah ar-Rahman ar-Rahim. The early complications of lung transplantation include primary graft dysfunction, acute cellular rejection, airway complications, infection, drug related complications, and non pulmonary complications. First, primary graft dysfunction characterized by lung injury in between pulmonary infiltrates, hypoxemia, diffuse alveolar hemorrhage, or organizing pneumonia on biopsy within first 72 hours after transplant. Clinical severity ranges from very mild acute lung injury to acute respiratory distress syndrome, ARDS, presumably related to preservations and ischemia, reperfusion injury, exclude other causes such as volume overload, pneumonia, hyperacute rejection, occlusion of venous anastomosis, and aspiration. The treatment is supportive, mechanical ventilation, or ECMO. The mortality rate is high. It ranges between 40 to 60%. Second, the acute cellular rejection. Acute cellular rejection is common and results from alloreactive T cell reaching to donor HLA and other antigens. Acute cellular rejection occurs particularly within 3 months of transplant and affects approximately 60% in the first year. It is rare after 12 months if adherence with medications is maintained. Asymptomatic or may be associated with malaise, fever, dyspnea, cough, hypoxia, may present similarly to pneumonia or cryptogenic organizing pneumonia, COP. Chest radiograph may be normal or show non-specific infiltrates. Common finding is fall in spirometry more than 10%, although this does not distinguish from other complications, particularly infection. Ideally confirmed histologically, transbronchial biopsies are safe and typically show perivascular lymphocytic infiltrates. Routine surveillance and transbronchial biopsy can be used to detect acute rejection prior to falls in lung function. Treatment: IV methylprednisolone pulses are given within the first 3 months of transplant. After this, high dose oral corticosteroids are used. The majority of patients respond quickly to augmented immunosuppression. Recurrent acute rejection is a risk factor for the development of bronchiolitis obliterans syndrome. Acute rejection is an uncommon cause of breathlessness after 3 months, and the other common causes of shortness of breath should be considered. Antibody mediated allograft rejection is increasingly recognized, and its optimal management is currently unclear. Treatment may be attempted with IV immunoglobulins, plasmapheresis, or rituximab. The airway complications include anastomotic stenosis, most common and typically occurs weeks to months after transplant, suggested clinically by localized wheeze, recurrent pneumonia, or suboptimal lung function. Treat with balloon dilatation, sometimes repeated, or stent placement via bronchoscopy. Complete dehiscence of bronchial anastomosis is now rare and requires immediate surgery or retransplantation. Partial dehiscence is managed conservatively. Drain pneumothorax, reduce steroid dose. The infection. Bacteria may occur early, first months after transplant, or late, associated with bronchiolitis obliterans, most commonly due to gram-negative organisms, particularly Pseudomonas aeruginosa. Recipients with cystic fibrosis are not at greater risk than other patients. An exception is Babesia colonization, which is associated with a high risk of often fatal post-operative infections. Cytomegalovirus seronegative recipients from seropositive donors are at particular risk of severe infection, including pneumonitis. This is usually treated successfully with ganciclovir. Increased risk of bacterial or fungal superinfection. Ganciclovir prophylaxis probably results in later less severe infection. Cytomegalovirus infection appears to be a risk factor for development of bronchiolitis obliterans. Aspergillus frequently colonizes the airway after a lung transplant, but clinically, apparent infection develops in only a minority of patients, and the peak disease incidence is at 2 months after transplant. Sites of disease include airways, may lead to mucosal edema, ulceration, and pseudomembrane usually respond to itraconazole, voriconazole, or amphotericin B. Fresh bronchial anastomosis, lung parenchyma, and disseminated aspergillosis associated with high mortality. Drug related complications. Immunosuppressive drugs must be taken lifelong following transplantation. Agents used include cyclosporin or tacrolimus, azathioprine, or mycophenolate mofetil, MMF, and prednisolone. They are associated with many drug interactions and side effects, particularly nephrotoxicity and osteoporosis. Pulmonary toxicity is described secondary to sirolimus and everolimus. Cyclosporin and tacrolimus and sirolimus blood levels requires close monitoring. The non-pulmonary complications include venous thromboembolism and cardiac arrhythmias are not uncommon following lung transplantation. Hyperammonemia is a rare but serious early complication. Long-term complications include hypertension, renal impairment, the hyperlipidemia, diabetes, stroke, and potentially ischemic heart disease. Remember also complications of the underlying disease as for example distal intestinal obstruction syndrome in patients with cystic fibrosis,